Psychiatry and dermatology have a lot in common, and dermatological conditions can end up with psychiatric manifestations, as well as psychiatric conditions can end up with dermatological manifestations. My name is Dr. Abraham from A&E, Specialist Dermatology, and we shall be talking about obsessive-compulsive disorder and related disorders in dermatology that we usually see in our patients. On the open screen, we can see a picture of someone continuously washing their hands, and this could be a psychiatric condition, but later on it can give us a dermatological manifestation. So when you're treating patients in psychiatry, it should be very key to note that these conditions can also come with other accessory conditions that may need an interdisciplinary approach to make sure that our patients get the best out of us. So to start with this explanation, when you look at this schematic diagram illustrated here, it shows you that in dermatology, we have psychiatric conditions and we classify them depending on the subgroups that I've highlighted here in these tables or in this picture. So to start with, we have what we call primary psychiatric disorders. And in this case, we have different spectrums. We have schizophrenia and its spectrum. So we can have dermatological conditions manifesting as a complication or as a because of the underlying psychiatric condition in the schizophrenia spectrum. And this one, we can talk about the region of parasitosis, or even in the Mongelon disease. Then we have OCD and related conditions. And here we can have the body dysmorphic disorders, trichotillomania, excoriation disorders, acne excoriae, and then body focus repetitive behavior disorders, and so on and so forth. So still, we can also have what we call secondary psychiatric disorders. And in this case, we can have other things like anxiety, depression, adjustment disorders manifesting with dermatological or skin conditions. We can also have psychogenic pruritus and dysthesias, and this we shall have a session of its own to look at this. And then we can also have physiological disorders. So to look into the details, when you look at obsessive-compulsive disorder, commonly known as OCD, we look at this condition as a chronic mental condition whereby a person has these uncontrolled recurring thoughts, what we call obsessions, and or behaviors, or what we call compulsions. So in this case, a person, for example, has a thought that maybe their door is not locked, and that thought cannot go until when they are compelled or they are forced to go and check out the door. So the thought is the obsession, and the act of responding to that thought is what we call a compulsion. So in symptoms, an obsession is usually very persistent, it is unwanted, and it can be either thoughts, fears, or even urges to do particular actions. When you go to compulsions, these are now actions. So someone gets repetitive behaviors, abnormal mental acts that are performed in order to relieve or reduce anxiety that comes with the thoughts that are persistent in this individual's thought process. The prevalence of OCD ranges all the way from 1.1 to 1.8%, with a slight female predominancy. However, this prevalence may be a little bit lower compared to what we see in the clinic. It may be even up to 10%. So when you're characterizing or when you are diagnosing the psychiatric disorder, we usually use a DSM-5 is the current updated criterion that we use when you're diagnosing these conditions. And for OCD, the DSM-5 has the following criteria that someone should feel before you can make this diagnosis. So someone should have presence of obsessions or compulsions, or have both. Then under obsessions, someone should have these recurrent persistent thoughts or urges that are intuitive and are causing significant anxiety or distress. So after having this, there should be an attempt by the same individual to try and ignore or suppress, but they can't neutralize the thoughts or any other actions. When you go to compulsion, we look at them as repetitive behaviors, including things like handshaking, like chewing, or even mental acts like counting or repeating that the individual feels driven to perform or to do in response to the obsessions that they have. And these behaviors can act they do them in an attempt to prevent the anxiety that comes with the obsessions or with the thoughts and ideas that they have in their brain. So they try to perform these acts in an attempt to reduce the anxiety or the distress that comes from the obsessions. And all this cannot be applied until when they have an effect on the social or the general functioning of the individual. For example, if you have a thought that is persistent, but doesn't stop you from doing your daily routine or your daily work, we can call that an obsession. And if it doesn't waste your time, if you don't spend significant amount of time on this thought, it doesn't qualify to be an obsession. So it becomes so if it has a significant effect on your functionality as an individual. And in this case, it has to impair or cause significant distress. So the key points to note when you are to remember OCD, what should you put in your mind? One, that in this case, it causes significant distress. That includes in your social, occupational, or other areas of functioning, and the disturbance is not due to substance use or any other medical condition. So if you have another condition that can explain the current trend or the current process that an individual is going through, then that is to be OCD. For example, if someone is a drug addict patient and all the time they have this craving, they are looking around to look for alcohol, they're obsessed with looking for that alcohol. In that case, the diagnosis will change from OCD, then you are now looking at a drug-related or drug abuse disorder of a kind. So in this case, you should make sure that the obsessions, the compulsions, they cannot be explained by any other underlying psychiatric or medical condition. And in terms of treatment, this treatment usually will use cognitive behavior therapy with exposure response prevention. We can also use selective serotonin reuptake inhibitors and then psychosocial interventions, including putting them in groups, counseling and guidance, occupational therapy, and the rest. So when you look at the right-hand corner of the slide, you'll see this picture. This picture, at least you put it in your mind, it will help you remember OCD. We have a lady here having thoughts that not going away, which thoughts are persistent. Maybe she's thinking that, oh, she did not lock the door. So the thought will not settle until when she has gone or until when she's compelled to go and check the door if the door is locked. And you may find that this door actually is locked. Then she comes back and sleeps. Then after a few minutes, she remembers that, did I actually close the door? Then she has to go back. So at the end of it all, there's a waste of time. There's an effect on even sleeping patterns. So that one becomes OCD. So when you go to the related conditions in dermatology that can manifest in our clinics as dermatologists, the first one is the body dysmorphic disorder. And this one, we look at it as a mental health condition in which a person becomes obsessed with perceived defects or flaws in their appearance, which are often not noticeable by other people. So in this case, someone may have maybe a little tiny scar of that size, maybe even less than 0.1 centimeters in diameter, but to them, it looks like it is a very big scar, about 20 centimeters in diameter. And in this case, for them, they would think that the scar is too bad and other people are looking at it and judging them actually, yet in actual sense, people are not even noticing it. So that is what we would call body dysmorphic disorder. So symptoms could include frequent mirror checking. Someone all the time is in the loose trying to check out and see if the scar has grown bigger, trying to manipulate the skin and see if they can make it to fade, something like that. People will start avoiding social gatherings or in situations which would expose them to be seen by other people. Then we'll see people who are having excessive grooming or seeking reassurance, asking you all the time, do I look beautiful? Does this look fine? Is this fine? So they're always seeking for reassurance, and they'll be combing their hair, trying to look nice, reapplying makeup every other time. So at the end of it all, the time they are consuming doing these particular events is actually having an impact on their functionality. The causes have been attributed to be genetic predisposition, brain differences, cultural pressures, traumatic experience. Maybe someone was maybe gang raped one time, so that trauma can now expose them and be like, maybe someone thinks they are not looking nice because of actually what happened to them in history. Still in medication, we can do CBD, which is cognitive behavior therapy. We can have medication and then also put them in support groups. So in the DSM-5 classification or criteria, so we have these points that someone should be preoccupied with one or more perceived flaws or defects in their physical appearance that are not noticeable or appear to be slight to others. Then at one point, the individual has performed repetitive behaviors like mirror checking, like excessive grooming, mental acts like comparing appearance with others, and all this is attempted like to seek approval and to be satisfied, at least to seek that confidence from others. Then this preoccupation causes significant distress and impairment in their social, occupational, or even other areas of functioning. And in this case, the specifier would be muscle dysmorphia. Someone is preoccupied with bodybuilding, being too small or insufficiently muscular, like for men. And then these preoccupations cannot be actually explained by any other concerns of maybe body fat or weight in an individual with an eating disorder. So to summarize this for you, what you have to remember when it comes to body dysmorphic disorder, that one, someone is preoccupied with their perceived flaws or defects that others actually don't appear to notice. Then two, this individual has done some repetitive behaviors in an attempt to see the progress of these flaws that they have. Then three, these preoccupations should impair their functionality. And four, they should not be explained by any other underlying medical or psychiatric condition. And five, they have a significant effect on their general well-being. So this is what I've mentioned, that point to note. The prevalence of this condition, like in dermatology, can go as high as 15%. So you have to be very cautious as you're seeing your patients, because 15% of them may be having a body dysmorphic disorder. And oftentimes it begins in late adolescence and early adulthood, where individuals are now seeking mates. They're seeking to upgrade in their careers, and they think that their outward appearance has a significant impact on their success. So they start to focus on all the minute things, details that are on their bodies or skin. So these preoccupations have been, all these people have been seen to do a lot of things, including frequent concerns about their skin color, hair, nose, breasts, and genitalia, and they have ended up actually going for cosmetic surgeries to try and boost their appearance, or to try and do something about their flaws. So when you're seeing patients and then they're complaining, maybe their skin is not balanced, maybe they have so much scars that people are judging them, maybe when you're seeing them from a distance, maybe their nose looks ugly. So when you see such things, you don't have to turn them down. When someone complains of that, you actually have to take them serious. And then in the management approach, you have to involve a psychiatrist or a psychologist, so that you help these patients better. So another condition that we usually see in dermatology, which is related to OCD, is what we call body-focused repetitive behaviors. And this is a group of disorders that usually involve repetitive or compulsive behaviors directed to someone's body. And eventually, this can result into damaging the skin. And these examples that we usually see in dermatology, we have trichotillomania, which is hair pulling. We have excoriation disorder, which is skin picking disorder. And in this case, we have recurrent urges to engage in body-focused behaviors, like maybe licking the tongue, licking the lips, like biting the nails. So something that ends up actually manifesting on the skin as damage because of repetitive behavior to distort the structure of that particular component of the skin. So these are examples of body-focused disorders. And if you are to go through them, we can start with this one, lip licking. And we know that in lip licking, someone will continuously lick their lips using the tongue and using the saliva in the mouth to keep them moisturized. And at the end of it all, they can end up with irritant contact dermatitis affecting the lips. So in this case, you have to be very careful. If you see someone with lip lickers dermatitis, you should investigate any underlying psychological or psychiatric condition. Then another one is lip picking or biting. This has been shown in people who are trying to calm themselves down, who are anxious, distressed, and they're trying to find something to calm them down. And you find that generally in the general population, you find almost everyone has something they usually do in case they're anxious. We've seen some shaking, some maybe repressing whatever they say with connecting words like So those things are very, very important. And if they have a skin manifestation, you should also involve a psychiatric or psychologist when you're managing such patients. Other examples include cheek chewing, cuticle pulling, nail biting, thumb or finger sucking, nose picking, and the rest. So looking at the first one, the one we call excoriation disorder or skin picking disorder. So in this disorder, we call it a mental disorder where the individual repeatedly picks at their skin, causing damage. So in this case, someone continuously picks small amounts or small pieces from their skin, and at the end of it all, they have skin condition. So in symptomatology, you'll have recurrent skin picking leading to lesion, failed attempt to decrease the behavior, and then significant distress and impairment due to these acts. So this condition has been linked to OCD. That's why we are discussing it under OCD, and also body dysmorphic disorder, stress, and anxiety. So in the DSM-5, still we look at the criteria to include recurrent skin picking resulting into skin lesions, repeated attempts to decrease or stop the behavior, but these are usually not successful. And then the skin picking usually causes significant distress or impairment in their social, occupational, or even other areas of functioning. And then skin picking is not attributable to any psychological effect of substance abuse or any other underlying medical conditions like scabies, which can usually be very pruritic. So skin picking can also not be explained by symptoms of another mental disorder like delusions or even hallucinations. So that's why when you're making this diagnosis, it looks like more diagnosis of exclusion 1. You should not have any other psychiatric condition that can explain the symptoms, including the things of delusions and hallucinations. Then there should not be any psychological effect of drug abuse, as you mentioned earlier, and there should be an effect on functioning, and someone should have at least an attempt to try and stop this behavior of skin picking, and it should be recurrent. And age of onset usually also in adolescence, and it can persist into adulthood. There has been a family history of OCD that has been associated with this condition, stress, boredom, and anxiety, all of them being risk factors. So in terms of treatment, we shall still do our cognitive behavior therapy. Then particularly, we can do habit reversal training in this case, where you try to teach this individual to do something else that can be maybe substituted with the skin picking disorder. Then we can also give selective serotonin reuptake inhibitors as medications. The next one is acne excoriation. So acne excoriation is also taken to be a subset of excoriation disorder, where the individual picks on acne lesions leading to scarring and then further skin damage. So in this case, someone can have a mild to moderate form of acne, but they tend to pick every appearing acne lesion until when they have eroded the area, causing significant erosions on their skin. And see, in symptomatology, someone will have this constant obsession to pick on the acne pimples. Someone will have scarring and then open sores or wounds on presentation. And the preoccupation with the skin appearance will be so significant. They're always worried that the pimples are so bad, so they want to take them away or get rid of them. And someone will have a lot of body image concern. Some of them are usually stressed and anxious. And in terms of treatment, this is one of the form of acne that in dermatology we take to be severe because you know the psychological impact. So we tend to give the high-end medication, isotretinoin, to try and get rid of all the residual possible acne so that someone can now settle. And then this one is usually combined with psychological therapies like CBD. So in the DSM-5 classification of acne excoriation, we have it being characterized by obsessive picking at acne lesions and consequently leading to scarring, infection, and tissue damage. So this is how it will look like. Someone will continuously pick on their acne lesion. Every time it comes, like this one, then they will pick on it, and you end up with these erosions and scarring and wounds, or even in minor or mild acne. The next one is trichotillomania, which we call hair pulling disorder. This is when we look at it as a recurrent, irresistible urge to pull one's hair, leading to noticeable hair loss. So this is one of the rare, but rare at the same time common dermatological condition. And when you see it, these patients should be taken care of nicely because you should involve the team to make sure you rule out what is causing this problem. So in symptomatology, you have individuals pulling on their hair on the scalp or eyebrows or eyelashes or any other area with hair. And because of this, they usually get a relief after pulling out the hair. So it's like afterwards, they feel this relief that something has gone out of way. And at the end of it all, you have significant hair loss, thinning, and also bald patches, which can be on the scalp, on the eyebrows, or even in the axilla. There has been a genetic predisposition associated with this condition, but also attributed to stress, anxiety, and other OCD-related conditions. So still in therapy, we do cognitive behavior therapy, we can do habit reversal, and then we can do medication, but still these patients are managed together with psychiatrists and psychologists. In the DSM-5, we have recurrent hair pulling out of one's hair, resulting into hair loss. Then someone should have an attempt to decrease or stop the behavior, but without success. And then hair pulling causes significant distress and impairment in their social, occupational, or other important areas of functioning. And hair pulling or hair loss is not attributable to any other medical or dermatological conditions. For example, alopecia areata can also give those annular patches of hair loss. So, and it should also not be explained by any other mental disorder. So when you look at this picture here, so we see someone having this patch of hair loss on the scalp, which was resulting from hair pulling. So this was a lady that we saw at our clinic, and when we investigated further, we came to realize that she had lost a loved one and she was not coping up with that stress. So she ended up doing this habit of pulling out hair continuously, and after involving psychiatrists and psychologists, was able to get back her hair. So then we will continue to the second part of this session where we are looking at the somatic symptoms and related disorders. And in this case, we shall look at dermatitis artefacta as one of the conditions that end up with dermatological implication. So when you look at somatic symptoms and related disorders, we look at this condition to involve excessive focus on physical symptoms that cause significant distress and impairment, often without identifiable medical cause. So in this case, someone focuses on the physical symptoms, and at the end of it all, they end up damaging the skin. So there are so many disorders that fall under this group, but of dermatological significance, we have factitious disorders, and that's where we have our dermatitis artefacta. So when you look at dermatitis artefacta, or what we call self-inflicted skin disorder, in this case, we look at it as a condition in which an individual deliberately produces skin lesions through various methods that could include scratching, rubbing, burning, picking, and but they deny that these lesions were self-inflicted. So we see someone with a wound with irregular borders on areas which can be accessed easily, maybe the lower limbs or upper limbs. But then when you ask them how did these lesions come about, they cannot explain how they came about, and they will not tell you that it is actually them. They'll actually deny that it is not me who brought these lesions, but something else did. And that's when you have to think about dermatitis artefacta. Often these lesions appear in areas which are accessible to the hands, especially the face, the arms, and the lower limbs. And individual will deny the knowledge of how these lesions occurred. They will not have a clear history, as we see in other dermatological conditions, someone telling you it started as a pimple, then grew to become maybe something bigger, maybe a rash, something like that. That history will not be there in this case. So frequently, this condition has been linked to underlying psychiatric condition, such as personality disorders or even factitious disorder. So to continue, as you can see in this picture, we see these wounds with irregular borders, irregular patterns that cannot be explained almost by any other dermatological condition. So when you see such a manifestation, when you're examining your patients, when you see this pattern, that the lesions that you're seeing, based on your knowledge, cannot be explained by any other dermatological condition, and they are in accessible areas, then a dermatitis artefacta should be in one of your differentials. So in symptoms, we can have erythema, we can have ulcers, scars, or wounds of different ages with bizarre shapes and geometry patterns, and they usually have a sudden onset without identifiable medical cause. So the causes have been linked to psychological distress or desire for medical attention, or even any underlying emotional trauma. So you can see these conditions maybe in elderly people living with other chronic conditions, and every time they feel neglected, they'll end up inflicting or causing damage to their bodies such that they seek medical attention. Actually, these patients be looking for someone to talk to, someone to comfort them, but maybe if they're ignored, they end up in this state. And still, when you're treating these patients, it is usually a multidisciplinary approach. And after taking care of the lesions dermatologically, maybe giving an antibiotic if they're infected, you have to involve a psychiatrist to give their part of medication, and these patients will be followed up until when they feel better. So the treatment approaches would include the following. For cognitive behavior therapy, this one I've been talking about it. Usually, this one focuses on the challenging distorted thoughts, and then you have to modify the compulsive behaviors, and then you can have habit reversal training. In this case, you replace some whole habits with something else. Maybe you get them involved in sports so that every time they are busy, and by the time they go to bed, they are very exhausted, to focus on their bodies. Then you can do medications at the worst end, or when things are out of hand. And in this case, you can have use of selective serotonin reuptake inhibitors. And other pharmacological drugs, we can give anxiolytics, antidepressants, and psychotics, depending on the severity of the condition. Then we can also put them in support groups or peer support. And in this case, you identify people with the same problem, and then you put them together so that they talk about the experience, share their how the disease is taking them, and at the end of it all, this rehabilitation can give a good outcome. So this table tries to summarize the different drugs that we can use. And in your free time, you can just pause the video, take a screenshot, and then you go through it. So if you are to look at this, if someone has conditions that at the end of anxiety, we can give anxiolytic medications. So depending on the extent, we can give drugs like clonazepam, lorazepam, a different dose depending on the weight of the person. If it is so severe, then you can do maybe every 6 to 8 hours, or even once a day if it's enough to calm down the patient. And if in case of chronic anxiety, we can shift to other drugs like other anxiolytic drugs like buspirone and the rest. We can also give selective serotonin uptake inhibitors, and then the tricyclic antidepressants like doxepin and the rest. We can also give serotonin norepinephrine uptake inhibitors, though this is not really available in our setting. So in case someone has depression, then you can give drugs that have antidepressant effects, and these are the ones that listed: SSRIs, and then the tricyclic antidepressants. So if someone has psychotic tendencies or psychosis, then we can have antipsychotic medications. So if someone has delusions, what, and the rest of parasitosis, then we can give them drugs like risperidone, like olanzapine. These are common in our setting, but if in better settings, you can also give the pimozidine. And then if someone has obsessive-compulsive disorder like OCD, then we can give in category of selective serotonin uptake inhibitors, even tricyclic antidepressants, and also serotonin and norepinephrine uptake inhibitors. So what is the impact of these conditions on the daily life of the patient? One, these conditions, if you don't address them, they can spill over into psychological effects, including chronic anxiety, depression, and then obsessive focus on the appearance or even behaviors. So in this case, you have to handle them with the respect that they deserve. And they can also have actually physical impact on the patient. So if you have an excoriation disorder, you end up with scarring, wounds. If someone has that tendency of forming keloids, you'll now end up with keloids all over the body. And you can end up with hair loss, which can affect someone's body image, how they look like. And you can end up with superimposed skin infections because of the repetitive damage to the skin. And it can also have a social impact. For example, if someone's appearance affects how they think others are looking at them, they may end up even not attending class, missing important meetings. Because of this, even their performance, they can go down, they can lose their jobs. So all this is something that someone should address. Thank you very much. I am Dr. Abraham from Dermatology. See you in the next session. God bless you.